You have the final exam, and you know there's a review next week, and the exam is Friday of next week in here. And one or two of you that have special needs have talked to me, so I think everything is taken care of. Now, what are your fears for the exam? Let me ask you that. No comments.
It's tricky. It's like a debate. You know how like the answers can make sense and picking the best answer based on your judgment?
Yeah, most of the questions will be analytic. In other words, they will not ask you a straightforward question and give you straightforward answers. It'll be a matter of judgment. You're right. Because all of nursing or any of the medical sciences are judgment. If you can't put the facts into context and make judgment, it's impossible for you to continue. All right, so you're right. That is the tricky part. Yep.
It's not cumulative?
What?
The exam is not cumulative?
I said that it is cumulative, but there will be very, very few questions from the first half. And you see on the blueprint, most of the questions are from ethics, law, and legislation. All right? Now, we covered legislation the last week we were together, very briefly. I mean, that you can read. It is important to know about Medicare, Medicaid, Social Security. You can ask any questions you want, but it's straightforward. We have an extensive range of programs in the United States to cover people's health care. We do not, as we were characterized in the last election, provide no one with nothing. There are a range of programs. The confusion is that we're a country that is governed by federalism. Remember, we use that word? Which means that it's a group of entities that agree to come together for some very essential things, but in essence, each entity, which are the 50 states, makes its own law. And those laws are, for the most part, similar, but there is a difference. In New Jersey, we have dramatic health coverage which exceeds the nation. We have health coverage for children, minors. Now it's up to 26. Up to 400% of the poverty level. We have had a drug program for senior citizens before Medicare Part D, which is the national program and better than Medicare Part D. And that is why the governor has secured an exemption for New Jersey from the new federal laws, because he feels we have more options here and better options. And I told you, although I'm not going to ask you, but New York State, and particularly New York City, Manhattan, is even better than New Jersey. So that's why you see relocation in this country. You see many people who relocate to New Jersey when they have certain health care problems. Another example of that, and one that we've talked about, is services for autistic children. New Jersey has the most dense network of autistic services of any state in the U.S. And a lot of those are provided by state government, others by local government. It's the same process. You have the nation, which is made up of the states, which have power of health, education, and welfare, responsibility for that. The government has made certain demands on the states, but still they're minimal, and many states have come through with more. And then in each state, there is a further reductionist attitude to the municipalities. And there are municipalities which give certain health benefits that others do not give. For instance, with autism, the municipalities in the northern part of this state give much richer health benefits to autistic children than certain municipalities in the southern part of the state. But that's the way the U.S. is run. So it does take a lot of smarts on the part of people who are needy, who need health benefits, to find out what is available to them. And that's part of the system here in the States. We're committed to freedom of choice, individualism, and personal responsibility. We always have been. Now that could change as your cultural mix changes. Could new cultures coming here, will they be assimilated into the American ethos? Or will they continue to live according to their ethos that they brought here? This is why there is such a need in this country for social services and for some of the new programs that the new healthcare law is birthing. We mentioned these, and I know it's hard to remember everything. And you don't have to remember detail, but you have to remember the general pattern. This is why there is so much attraction for the accountable care organizations, for the federal health centers, for the navigator programs. We mentioned all these. These are all programs under the new health care that will be funded and have a critical need for advanced practice nurses. They are programs which help the needy person, and by needy I mean the person in some mental or physical need. I don't mean needy as far as money, because many of these programs are covered by insurances, by Medicare, Medicaid, but they're all programs that help you figure out for you what are the things that are available to you and help you navigate the system. That's the name of one of the programs, the Navigator program. Started in New York City, I think in the Bronx, in Montefiore, has become very attractive. People who use physicians from that facility and who use the hospital are guided through the process by case managers, who I feel are best advanced practice nurses, but you never know who the boss has hired. But you need someone who is holistic. Someone asked me earlier, what does holistic care mean? Who gives holistic care? Holistic care, for the most part, is care that pays attention to body and mind, both, your social context, and for the most part are people who use complementary medicine. So they don't just buy into the traditional approaches to curing disease. They're also looking at the non-traditional. They're looking at Eastern medicine. They consider acupuncture. They consider herbs and vitamins. Traditional Western medicine is not truly holistic. All right? That's why it's said that this country is the best country to be sick in, but not the best country to be well in. All right? Because if you have serious problems, and you all know that, we have sheiks and presidents of governments all over the world flying into New York If you ever go to work in the major medical centers over there, most of them have a floor that is devoted to offshore patients because these noteworthy people fly here because there's nothing like American medicine. And they stay on these floors with their entourage of bodyguards or whoever. So there are these suites with multiple rooms. They're not coming here because the care is bad, let me tell you. They're coming here to get cured and go home. And if it's going to happen, it'll happen here. But health is a different issue. And all of these comprehensive team type of systems, the Navigator, the Accountable Care Organizations, all of them exist to meet all your needs, from primary care right through acute care and intensive care. All right? We have not spent that much of our attention on primary care. Now, you know what primary care is. Primary care is care given to a person to achieve a high-level wellness. It is care given to avoid disease, to cure minor ills, to maintain stabilization of chronic illness. All right? It's a lot of the stuff that years ago we did for ourselves, but we've become much more sophisticated. I don't know if that is good or bad. It started to, primary care came into its own right after World War II, because you had a lot of GIs going to war who came from areas in the States, both rural and urban, that had almost no care, except if you were very ill. And so GIs, general inductees with GIs, if you don't know what that is, soldiers and sailors who got drafted, got used to primary care. And they came back and they wanted it. And the unions began to establish themselves and began to lobby for better health benefits. And that's how we got where we are now. That's how you got from a budget that was a mere few cents in health care into one that is choking the nation right now. All right. Is there any questions about that whole pattern and about the patterns of care in the U.S.? All right. So now we're confronted with health care coverage, which is, I don't know what the latest statistics are, but probably almost, 60% provided by government through its major programs, Medicare, Medicaid, children's programs through the state. Most of the funding of care, 60% at least, is provided by government, and then a whole lot after that provided by the workplace. And then we have some people who aren't covered, who will be covered by this new insurance plan. What is your thoughts on that? What are your thoughts on the new insurance? We've talked about the ACA enough, affordable care, all right? It will bring everyone in under some type of insurance, forcing them to pay. The Supreme Court has said it's unconstitutional to levy a penalty on them if they don't get health insurance, but it's going to come from the state or federally somehow. What is your thought about that? Come on, you must have a thought. Okay, you're reticent to put it up there, yeah.
I don't feel like I've been following politics long enough to make a very sound argument, really voice my opinion in that way. But I know my uncle was in a very bad accident last summer, like swimming in the ocean. He almost drowned, he didn't really know how to walk and everything. And my aunt posted something on Facebook during the election, supporting him, saying how it was a good thing, how it's going to help a lot of people. Yeah, you might think it's wrong to force people to have something, but yeah, just going to help them. It's like forcing someone to wear a seatbelt.
All right, was he in an automobile accident?
No,
You said he almost drowned.
And he got pulled under somehow, and when he hit his back on the ground, he he couldn't swim to the surface.
Yeah,
he normally
okay.
would be able to.
All right. He was taken care of, right?
Yeah.
How? I don't mean good or bad.
Well,
Where did the funding come from? Because
that's where I'm not entirely sure. I don't know if she was basing her opinion off of her getting money from this new plan, or if they were using previous insurance that they had. So that's part of why I'm not sure about it.
yeah, if you have no money, you're processed, if you're a disability case, and that's what it sounds like, it's a disability case, but you're processed for either episodic or permanent disability. And with disability comes Medicaid. Now, in Medicaid, you're not allowed to pick your own doctor. Not every doctor takes Medicaid because the Medicaid fees that are paid for taking care of someone are grossly low. And grossly, I mean grossly. It would not allow a doctor to keep on the lights in their office. And that's why a lot of doctors now work for hospitals, are in group practices, which are PCs, professional corporations. It allows them to avoid some of the insurance risk. Insurance is a major cost to them. But regardless, anyone who has problems like that probably is processed for Medicaid, because unless he was working for someone that keeps him on disability and full salary for a long time. There are some companies which have that type of benefit, but usually it will be Medicaid. And Medicaid, now I would say someone like that, and who had to learn to walk and to talk again, there was brain damage, obviously, yeah. Would probably go to a rehab institute and would be taken there and taken care of by Medicaid. I've been around a long time, and I've been in many of these places and hospitals, etc., that have large Medicaid populations. And I've never seen a Medicaid patient have different care than one who is paying the full bill. You understand? And Medicaid gets very confusing, but if you own property, they do not expect you to sell the property because there's an expectation you're going to get better. If you're a millionaire, do they require that you spend down some of the money on your own behalf? Yes, because you're only allowed a certain amount of money in order to qualify for Medicaid. So it's hard to give you a clear-cut answer. How is he now?
He's good. I think it was more something with his spinal cord, so he didn't have to learn how to talk. It was really just they thought he was going to be paralyzed the rest of his life and not be able to walk. But he went to a rehab center, he can walk. He uses a cane, and he seems like he's 10 years older than he really is, but he's doing well. He'll be back at work probably next year.
Yeah, and there's still progress being made.
Yeah.
Yeah. So people are taken care of. They're not just cast adrift. If you haven't got the money, you get the same care. Now, it's interesting that if you talk to nurses in any of these hospitals around here, I'll bet you they don't know who's on Medicare. All right? Like Medicare, they might say, oh, well, Mr. Jones must be over 65, so he's probably on Medicare. Although a lot of people who are of Medicare age are not on Medicare. We have, I can't give you the percentage, it would be interesting. Go Google AARP. They have all of this. Their website is wonderful. There is a dramatic number of people who are over 65, that's the age you qualify for Medicare, who are still working. And if you're still working, you're still paying into Medicare, unemployment, everything else. So when people say those who are older should give up their jobs to make room for younger people, I wonder if they realize what a burden this is going to be on the country. That people who are working are paying. They're paying taxes, they're paying everything out of their salary. All right? So there's quite a difference. But the healthcare system is confusing. And again, that's why social service people are so invaluable. But people I know, once they become sick and they need the sources, learn themselves. They know more than the social service people because they're personally involved. They'll come into the hospital. I see them in one hospital I'm frequently at, and they come into admissions, and they'll say to the admitting clerk, listen, I could probably qualify for long-term care. That would get me on Medicare. They know the answers better than the admission clerks because we're not a stupid people. And we know you have to work the system here. The people who are excluded from ACA 2010, which will have full force by about 2014, the people who are excluded are aliens or immigrants which are here illegally. And that is no different than any other country. I gave you the example of the European Union, which, in my estimation, is trying to make themselves into another US of A, but it don't work. They don't talk to each other. They're fighting a picture in the Times yesterday, big achievement. Germany, France, and Italy were sitting together talking, and that's only Europe. All right? Well, of course, the EU is Europe. But they're trying to reach some agreement on health care. If people that are over the border working, for instance, a lot of Polish people working in Ireland, an awful lot. I think there's less migration now because there's fewer jobs. That economy has gone down. But at one point, it was absolutely full of people from Poland going to Ireland. But Ireland would not accept the Polish insurance. So if you got sick, bye-bye, go home. Because they would not, and Poland has a socialized medical system. But Ireland would not recognize it. And none of the countries will accept insurance across borders. Here, if you have Medicaid in one state, you go to another, it's very quickly processed and accepted. The reimbursement will not be at the same level. It'll be at the level of that host state, but still the patient will get the care. And as I was saying a minute ago, if you go into St. Michael's or a university, if you ask the nurses, they may know who's on Medicare, but I bet you half the time they're wrong. It's not, age is not an indication. But they don't know who's on Medicaid. And they don't know who's bad debt. Bad debt is a person who has not been processed for any social program. and has no insurance of their own but is sick. And here they're taken care of. And their bill is charged to a fund whereby the hospital gets reimbursement from Trenton once every quarter for a percentage of that. And some hospitals, like University Hospital, I think must be 90% bad debt. And some of those people can be processed for Medicaid, but it's done when they're in the hospital. They come in with no coverage at all. So my point being that it's the same care that a patient gets, whether they're paying from first dollar themselves or whether they're totally Medicaid. The nurses don't know, and that, I feel, is wrong. The nurse should know, because there are certain things which are different plan to plan. All right, give you an example when they're going home. Doctors are not aware of this, usually. Patients will have their prescription for drugs fully covered if the drugs are selected from a list, a formulary, that is available for Medicaid. If you have a physician that prescribes proprietary drugs and puts on the prescription, fill as noted. In other words, he won't allow or she won't allow generics to be used. This will create an awful bill for the patient when they get out, and most of them will just not take the pills. I feel all right today. Forget about it. I won't take it. You're talking about the difference between $2 or $3 and hundreds of dollars. And if the nurse knew this, he or she could prompt the provider to order properly. So I think the nurse should know whether they're on. It is hidden somewhere on the chart, or it should be. But I've never known of any nurses that took the time to understand. All right? Mm-hmm.
So with the Obamacare or ACA,
Yeah, whatever it
whatever it is it the government going to provide the insurance for the people, or do they have to go out and get their own insurance? Because my thinking is, if the people have to go out and get their own insurance, and they're already borderline poor or even in poverty, where are they going to get the money from? Depending on how much they have to pay for it also. Because a family of four paying
All right.
us.
It's my understanding, and I haven't read all 2,500 pages of ACA, but it's my understanding that each state was to establish a network of insurance plans. And again, it's the public and private sector working together. It is not the public setting up clinics and hiring doctors and nurses. You understand? It's working through what we have. And that is uniquely American. Uniquely American. We've been through this, all right? The decentralization to the states and the public and private sector working together, which happens in no other country, except some now are getting very vigorously into second insurance. I have a son who lives in London, and everyone he knows, well, these are younger people who have jobs or he wouldn't be there. He'd be on the next boat back, and they wouldn't keep him. But who have decent jobs, and they get a secondary insurance. So they have the National Health Service, and then they have a secondary insurance that picks up the tail, and that's the word you're going to hear, the tail of what is uncovered. The ACA required that each state form a network of insurance plans, and that the person be picked up through other social service agencies like unemployment or other types of agencies that touch them, and they be required to buy into that plan, or there would be a penalty. That's ACA. Our governor, and he's not the only governor, several other governors made appeal to the federal government to be exempt from that piece of the plan, saying that we have plans here that already cover everyone. And our plan is Medicaid of New Jersey, and Medicaid of New Jersey works through the existing insurance plans in the state. And all of them that the poor can select are managed care plans. That's important for you to know. And all of the plans that Obama required in his legislation were managed care plans. So we were ahead of the nation. And so our governor applied for an exception, the exception being that if New Jersey provides the coverage to everyone through their own system, that we would be allowed to proceed with that system. Is that clear now? Yeah, that's how it's going. But every state has to provide this network of plans, and the person will be picked up. Where will everyone will be covered, all right? I would say that initially, everyone that isn't a participant in one plan or the other will be directed into a certain plan that the government selects that is more cost efficient. All right? How will you be picked up? At unemployment, whenever you go to any healthcare facility, if you go to a hospital or a clinic, Planned Parenthood, anything, you'll be asked, what is your coverage? If you have none, you'll be designated and given one. A penalty for not being covered has been judged unconstitutional, I think. The Supreme Court decision is a little confusing to me, but what they're saying is you can't force a citizen of this country, a citizen now, they're talking citizens, you can't force a citizen to pay a penalty for something or to join something if they don't want to. All right, that's the Supreme Court. And that will be worked out with time. The important thing to realize is that everyone who's a citizen or a legal resident of the country will have coverage. All right, of some type. Okay? Is that clear? Any other questions about the health system in general? Nursing homes are part of the health system. And you now know that most of the dollars out of Medicaid go to nursing homes. I mean, isn't that sick? I think it's sick. Most of the dollars go to the frailest, the least able of our citizens, and most of the dollars in Medicare are spent in the last month of life. Go on Google and again look at AARP or CMS.com. That's the Centers for Medicare and Medicaid Services, and you can see those statistics. So we're investing because we are a high-tech civilization. We're investing the most in people who will not live. Now, don't go out of here and say, oh, that Dr. Joel, she's anti-American. And I don't mean our oldest citizens don't deserve the best. but most of them would not choose to be in a nursing home. And until lately, the only way you could get Medicaid is to go in a nursing home. There are more Medicaid dollars spent on nursing homes than any other service. And in New Jersey, again, I believe in your state. That's why we have to help the southern part get back on its feet, all right? New Jersey passed legislation about a year and a half ago, and we've mentioned this. It has a big, complicated title, but its concept is that money will follow the person, not the person the money. In other words, people go to nursing homes because it will be paid. But this legislation says anyone that qualifies for Medicaid, the poverty program, and is nursing home eligible, the state will give them the money in their hand, and they can arrange to have these services at home. Now, there's a vast debate about this, and a good debate. Is it better for people to be in nursing homes? But the elderly people I've talked to do not want to be there. There has been a lot of research funded in the state to see how we could get people out of nursing homes and let them take advantage of this. It seems that people who are already in nursing homes don't do well leaving. They've been socialized into the nursing home. They're afraid to go home. But people who have never gone to the nursing home are happier if they're at home. So what I'm saying is what AARP New Jersey has decided. We have to work to keep people out. That people who are in, it would be cruel to make them move out. But people who never went, and those are chiefly people who are in hospital. If you're an elderly person and you're in the hospital, before you go home, it was common to have a caseworker come see you and discuss which nursing home you want to go to. That discussion should change now.
Now, you have people that actually cannot take care of themselves.
Yes.
Like, I have a man who is actually, they had to put her in a nursing home because she wouldn't take her medication. Okay, so when you take her, you go in there, my mom will go over there to take her out for about a week or two, and you have to force her to take her medication, but when she's in the home, she takes it willingly.
Because she's given it.
Exactly, but my mom gives it to her also, but she just will not take it. She hides it underneath her tongue, she'll spit it out,
Yep.
she'll hide it in her food, but when she's at the nursing home, she physically takes it, and she actually enjoys being there versus, because she has the company now that versus when she was at home.
Yeah, and I think you're right. But there are a lot of people who are not appropriately placed. You have to look individually. And before, if you sign on for this legislation to get the money in your hand, there's a caseworker, or in New Jersey, I believe it's an advanced practice nurse who does intake on the case. And it would be up to him or her to decide whether this is a person who could live alone. And it's not alone, because that money is intended to pay for chore care, companion care, but you can hire anyone you want. And this is another weakness. You have to have caseworkers who are very vigilant, because you could have people who are not good at the job taking these jobs and doing nothing but accepting the pay. But it's, all right, another thing. Organizations that the person belonged to, or churches that they're members of, are networked into this person to try to diminish the isolation. So it's much harder to keep people outside. But to many people, going to the nursing home is considered the last step, that they'll never leave there. They're not thinking as much of the companionship as the fact that it's the last step. But you're right, there are some people. Well, what would you do with Michael, right? Michael. Yeah, with Michael's aunt. You got the picture? An elderly woman who, well, she's been in the nursing home quite a while now, right?
About 6 years, I guess. About 6 years.
6 years. I wouldn't attempt to get her out. She's been socialized into the nursing home. She's used to getting her pills from someone that comes around. But what would you do with a person who had these tendencies? There are a lot of older people who don't want to take the medication, who, even though you give it to them, they hide it under their tongue. That's common with psychiatric patients and with long-term care patients. It's amazing, even if you say, open your mouth and let me see. And I don't know if that's an invasion of privacy, but we've been doing it for generations. You look in there, you don't see the pill. There are places to hide it, believe me. They hide it and because they don't want to take it. What do you do with a person? Let's say this was a new admission, not there 6 years. You're there 6 years. It would be cruel to take someone like that unless I have a patient in one nursing home I'm in frequently, and Michael. And he was in there about 6 or 7 years. And he was discharged on this program. He was placed in an apartment there are 3 other guys. There are 3 bedrooms and a central living room. It's in a town close. And he takes the free transportation service every day and comes to the nursing home and works, does recreational things with the other patients, gives of his free time. He's wonderful. He's all with it. And he has his medication in a little pouch he carries around his neck. He's absolutely no trouble. What does he get? He eats in the employee cafeteria, so he gets a meal. But he never asks for anything or makes any demands. He finds that if he stays home, the time hangs on his hands, so he comes up to give free time. But what would you do with a patient like this, who, let's say she was admitted, she's uncooperative in her personal hygiene, and she is able to wash herself, to change herself. She won't take her medication. What would you do?
Do you mean as a nurse?
Yes, as a nurse, yeah. Or, that's a good question, or as a nurse taking advantage of the other providers in the home. As the nurse, you're in charge. All right, legally, in nursing homes, the nurse, the RN, is in charge. So what plan of care would you put in operation? Your goal would be, let's say, to keep her at home eventually, right? What would you do to get her to that point? Who?
First thing, you have to make the patient trust you, then they will listen to you.
It's a good point. Have the patient trust you. So that probably would mean giving her a certain amount of attention, knowing her family or visitors that come in. You don't have to make them your best buddy, but know something about them. Know something about where she would go to live if she went home. Know something about her, quote, normal life, what organizations she was in. Most organizations do not just cast you under the bus, when you get old. Most organizations, if you reach out to them for someone who has been a long-time member, will give you help. All right, what else do you do? What about the medication problem, the taking care of yourself problem?
Sorry, couldn't you slowly get work the social worker, get a home health aide, and slowly work her into her apartment. Like maybe go once a week and then come back 6 days and slowly get her to do that, or?
Yes, I think that would be excellent. It would be the nurse initiating it, but then talking to social service. You're right. What she's suggesting is, could you, like 1 day a week or 2 days a week, have her go to the apartment and stay there and have the services come in? I'm adding, maybe put her medications in something she wears around her neck. I just see this all the time. There are some nursing homes which allow self-medication. You have to get approval of the state, but that you can have the medication with you, and maybe you have to be prompted to take them. But if you're prompted, you'll go in there, and maybe the one with the red cap take once a day, and the one with the blue cap 12 and 6, or what have you. You had your hand up, Mike.
Now, it's, with her issue, it's more of a mental issue than with, as far as, because there are different stages, okay? Because my mom would go over there once or sometimes twice a week. They did have a home nurse coming in to check on her every other day.
When she was home.
When she was at home. Okay, so they did have people coming in regularly. They even had people coming in and cleaning the houses to give her some kind of company and companionship, but she still would not take her medication. She wouldn't bathe herself. She wouldn't clean up. She had to have that constant care. Because of her mental state.
I hear you.
But if you're looking at an elderly person, let's say somebody who broke their hip, or is afraid to go and go out and be by themselves again because it might happen to them again, then yes, I would say go out there and encourage them. Take them to their home. Let somebody come in there with them. And let the nurse come in there and help them out. Or like you said, wear the medication around the neck for people who can do that. But mental people is a totally different issue. Ballgame in itself, I believe.
All right, we're not talking about your aunt. We're talking about someone who is new to the home. I'm saying with her, to re-socialize her into being at home would probably be almost a lost cause.
Right, but also even in 6 months, if you're trying to give her a 6-month time period to come into this, because my mom's been working with her for years. She's had this, issue for years. So my mom's been working with her, and family members have been there with her, constant trying to encourage her to do this stuff, living on her own, but she still wouldn't. She just would not
Okay,
budge on doing
let
it.
me throw out 2 more problems which you have sorta, and they're common today. Nursing homes are also loaded with patients, or residents, they're not patients, residents, who have aged out of mental health. All right? Let me make that a little clearer. One nursing home that I'm in a lot has 600 beds, and at least has been cited by the state for overuse of psychiatric medication. The federal government has a provision for restraint of patients through Medicare, and most states have picked up the same standard for their Medicaid patients who are in nursing homes. And physical and chemical restraint is definitely out of order, all right? So physical restraint, we've more or less accepted. And you need a provider's order, an advanced practice nurse, or a doctor's order to put any sort of a physical restraint on a person. Remember I gave you the example of the old soldiers' home in Paramus, and how the mattresses they ordered for their patients are this thin, they're about this thick, foam mattresses. And if you come in at night and you walk through the halls, you think, my God, I'd never send anybody here. This place is a mess. because most of those mattresses are on the floor, purposely. They won't restrain their patients. So if you fall that much, you're not going to break a leg, right? If they put it on a bed and you fall out, you're going to break something because bones are very brittle. All right. So physical restraint has been more or less accepted. And it's not the family's decision to say, yes, you can restrain Dad. And in many nursing homes, you wouldn't consider it a restraint, but a tie is put around the waist of people and tied to the side of the bed so it can't climb out at night. Why would they climb out? Is their mental capacity challenged? No, they have to go to the bathroom. And most of them don't want to bother anyone. So they climb out and they fall in the meantime, all right? But another gray area is chemical restraint. And this nursing home uses more than the state feels should be used for chemical restraint. If you look at the patients, at least 1/3 of them have aged out of mental health facilities. They were in facilities because of their mental condition. They became too old and too frail, so they wind up in a nursing home. You can't stop giving a person psychiatric drugs when they've been taking them for 20 years. Do you understand? You just can't do it. The system has adjusted to this, and you can't do it. So one problem is aging out of mental health facilities. A lot of people are living longer, and they're becoming old in prisons, in psychiatric facilities, and so you have to make some accommodation for these type of people, and you have to medicate them properly. So the first thing I would say with your aunt, the poor lady, I hope she's not getting the vibes we're talking about her here, but I think an assessment is in order to see if, and I'm not pro-medication. I don't like chemical intervention, but it may be that she needs something to increase her cooperativeness. Now, if you're at home and you forget your pills, you don't want to take them, but if you're prompted, if you're in a nursing home and you're prompted, you'll take them. And there are different levels of prompting. There's verbal prompting, there's physical prompting. Here are your pills. As far as force, that is absolutely not acceptable anyplace, all right? There are systems today, and this is where we get creative, and you should anticipate when you get your RN license, whatever that is, seek jobs, and we're going to talk about some of these things today. Seek jobs that allow you to be creative. There are, for instance, the Bien-aime of Central Jersey has a program where people who would be in an institution but are at home can live at home if they're prompted to do certain things. So it doesn't have to be a nurse. It can be a staff worker who likes people, calls Mrs. Jones every day at 10 o'clock and asks her, Mrs. Jones, are you dressed for the day? Well, no, I just got up. Now, why don't you go pick out clothes, go in the bathroom and get washed and get dressed? And I'll call you back in an hour to see if you did it. Or, Mr. Smith, do you realize you have a medication to take now? And it's in the bottle on your sink with a red cap on it. Go take it. Oh, yes, I forgot. Do you understand the concept? There are ways to try to keep people home. I think if you've been in an institution for 6 or 7 or 10 years, It's cruel to take you out, put you back someplace alone, and expect that you're going to be self-sufficient. I feel it's cruel. But we want to try to keep people out, and that's one way the healthcare system will save a lot of money. The issue of companionship, that takes a lot of work, because a lot of people, the home is their companionship. If it wasn't for the people they meet at the home and that are around them all the time, they'd have no one. I realize that. And that takes work. All right? But in surveys, and maybe it's time for a new survey, but in the latest survey of older Americans, they see being institutionalized or going to a nursing home as taking away their civil liberties, as forcing them to go somewhere where in their head they see it as the last stop on the line. All right. Not many people have gone to nursing homes and then come out and lived a full life. That's reality. Okay?
In my town when I live, they provide like services for people, like elderly people who are over 70s, like from the city halls, and they call like for people who are willing to cooperate with them. Like they have like a station of the nurse in the city hall, and they call like every morning, like for example at 8 o'clock, like you mentioned, like you dress Mrs. Smith or whatever, and they call like 3-4 times during the day to make sure they be okay.
That's wonderful. There was a program like this, that started here in North Carolina, and I thought they would have made a fortune. It was a private program, never caught on. Now, is this at the town level, or is it for the country? Or maybe you don't know.
I'm not sure about other towns, but I know it's particularly in my town where I live. It's located in the city.
Okay. It's based in the city hall.
It's based in the city hall.
And people call from there.
Yeah.
And I don't think you always need a nurse. You don't need a nurse, quite frankly. In the program that VNACJ is Visiting Nurse Association of Central Jersey, it's the second largest one in the United States, next to VNA of New York, VNS, Visiting Nurse Service of New York. And I don't know exactly the extent of the services they provide, but I do know that they also have heart monitors that operate through the phone. And that's their congestive heart failure program. Some of you are shaking. You might have heard of this. They started it 10 years ago, but it's become fairly common. Someone will call the patient in the morning and ask how they are. The gentleman might say, well, I'm having some, not much, it doesn't bother me much, I'm having a little problem breathing. And for that, you need a nurse. So probably she'll ask, stay right by the phone, I'll have a nurse call you back. The nurse will call back and ask the patient to put the phone on their heart. And it's visually transposed, a picture of the heart through the phone. Now the phone has to be equipped for this, all right? If you're on this program, someone comes in and equips your phone, but it will tell the person on the other side, you don't have to be a doctor, whether the heart is beginning to have problems. If someone with a serious cardiac problem starts to have greater problems, it is usual that fluid backs up in the lung. And if you get it right away, you don't have to hospitalize them. They probably need a dose of a medication that promotes excretion of fluids, or somebody else might need an injection of something. So the nurse on the other side, him or her, might say to the patient, what medication do you have? And most of these patients are very current with what, well, I have this and that. All right, take one of those pills and call me back in an hour and a half. And for most people, you've avoided a hospitalization because this clears up very quickly. I had a father who had congestive heart failure, and that was a lot of years ago. And it was a very complicated, critical condition. He wound up in critical care and in the hospital, frequently went into pulmonary edema. That's the name for the condition when the lungs fill up with fluids. People feel as if they're drowning. That doesn't have to happen today, because as soon as there's a little build-up, you take a diuretic, that's what it's called, and the kidney starts to excrete the excess water. And in an hour or so, you're breathing better. So you can imagine the money this saves the nation. And I don't know how many VNAs, Visiting Nurse Associations, have these programs, but the one in New Jersey is based in Red Bank, but it has, I think, installations in like 130 communities. They have satellite offices all over, and they keep just thousands of patients out of the hospital. Now, with this patient I described to you, should a nurse get in and see him? Maybe you put it on the list, or you don't. You just keep discussing by telephone how he does, because these patients understand their conditions. And half of the success is due to education. You have to educate the patient to what their condition is, what's going on, and they live with it. Very hard to live with years ago, not so bad today. Okay. Any other questions? You see, but if you get out as an RN and you're working in home care, as soon as you become comfortable with your employer and where you're working, there's no reason you can't say, I've noticed a lot of the people I go in to see are congestive heart failure. Did you ever think of a telephone program for them? And do you want me to look into it? Maybe there's state funding, which there is. And you bring new ideas. All right, let's move on to some of the things we want to deal with today. I wanted to deal with socialization as a concept. Socialization is something all of you have been through. Let's see. Nothing's working. Woo! Is that better? Okay. I'm sure you've been socialized many times. You've been socialized into a family, most of you, or into a second family. If you get married or you're living with someone, that's the family, whether you see it as such or not. And it's re-socialization. You've been socialized as a student. You've been socialized as a worker. I bet you most of you, because most Rutgers students work somewhere, right? And you're going to be socialized as a new RN at some point. And there are 5 steps, which this is called an operational definition. And it's something that used to be taught here extensively because it's a concept that was used heavily by Hildegard Peplau. You remember who she is. She's a mother of psychiatric nursing. She stood where I'm standing at one point. She taught at Rutgers and established their psychiatric nursing program, graduate program, which is world famous. All right. An operational definition is a definition which shows the stages to get to a certain point. And here, it's role taking. When you decide to take on a role. And there are certain steps. When you go for a new job, you're going to first decide who the primary people are in that setting, the primary group. And then you're going to develop an interpersonal attachment with that group. You're not doing so well if you pick the wrong group. And you have to be shrewd in your observations. All right, you go for a new job. You immediately form an identity, and you select as your primary group a loser who works there, and you think they're really on top of it, and they're going to help you, and they're very verbal, so they're going to help you get ahead. But you choose the wrong group, and the loser is labeled as a loser by the boss, and because you buy into the loser's behavior, you're also labeled as a loser. You understand what I'm saying? All right. The third step is to get clarity on what the expectations are and see if you can make covert messages overt. The expectation here is that you come to class, and theoretically, I do not take attendance. You know that. I could take attendance, and you will find as you progress in the nursing program, because the classes are very small, attendance is taken every day, either by sight or in a book. Usually the professor will do it by sight if they feel secure enough, but then note it in a book. And if you miss, you're recorded and put on board. If you have a good excuse, fine. There are some exceptions made, but not too many exceptions. No exceptions in clinical work. I'm just warning you. If you miss a clinical day, you better be prepared to go in and make it up. If there is an instructor on site for that day, if they want to be nice, they'll take responsibility for you. But if not, you have to pay to have a faculty member go in with you, because you're not allowed in on your own. There has to be a faculty from Rutgers with you. So there are no exceptions to clinical days. There may be the exceptional students who an instructor feels is way ahead of the rest of the class, and one day will not hurt. But it is up to the instructor to make that judgment. So don't call down the instructor for it and demand proof. Come on. This is a political system here. You know that, right? And there are political ways to get through it. The one way to not get through it is to start in challenging the faculty. I just mentioned that because I had an incident with that yesterday. Not anyone getting on my case, but a student that I've had a few times. She's an exceptional student, but she doesn't know how to be political, calling me to say that an instructor was disrespectful to her. I said, oh my God, disrespectful. Did you deserve the respect? That's not it. She was going to report the instructor because she was disrespectful. Then, as we talked about it more, I wouldn't have been disrespectful. I would have failed her. That's a good way to show disrespect. You know, you just fail the course. Whereas the instructor was trying to push her into doing her best and to try to recoup that course for the semester. But anyway. All right, so the third step is to clarify expectations for them and make covert messages overt, but it's not always possible. So sometimes you have to trust your best judgment. The last two steps are the most important. Step 4 is negotiating to find out how much latitude you have between the real situation and the ideal. To put this, all right, you're working at Burger King. I don't know where you work, but you're working at Burger King. I know a few students that do, and I ask them, why do you work at Burger King? And they say, because I've been working there for 4 years. I'm in the union. They get health benefits, even for half-time, and the salary is good. They're a supervisor at Burger King, and I think that's wonderful. But anyway, you have to know how much you can negotiate wherever you're working between the real and the ideal. You may be working at Burger King. Your job description may call for you to clean up at the end of the day. But what latitude do you have? Can you ask the other people to clean up because you have a bad back or something? Are you perceived as having more authority than you do? And will they do these type of things to keep on the good side of you? As an employee, are never allowed to, and some stores, I know this is true, you're never allowed to go in the register. But pretty frequently, your boss will ask you to tally the register at night. And you do it because it's for him or for her, and you know how to do it, etc. So you have to begin to get an idea of what the difference is between the ideal and the real, and determine how much freedom you have to do what you want. That's role shaping. And then role taking is continuing to support the way you want the role to be. Now, there are many workplace cues which will allow you to tell how much flexibility there is in socialization, how much flexibility you have to do what you like rather than following the job description or the directive of the boss to the letter. Highly precise and detailed job. Now, all right, why should I tell you this? First of all, because you're socializing into a role, not a job, but a role constantly, as I pointed out to you. And secondly, because this is of tremendous value when you take a job as a nurse. And that's what I'm targeting. That for you is a few years old. But if you're smart, you'll seek out internship programs. You would be qualified to do that once you hit the junior year, right before the junior year, in fact. They'll take you. You should look for the best places to apply to because most places will select their future employees from that intern group and jobs are hard to come by today. And again, let me reinforce, we have had no problem with baccalaureate graduates, but associate degree graduates are there years out of school and can't get a job. So let's not minimize, and you want to get the best jobs. So you should be looking for an internship program as soon as it's possible. How do you start? You probably go over to Kyle Warren's office on the right-hand side when you come in nursing and ask him if he can give you some advice. If not, you ask your instructors. You don't have to be in this class. You can always send me an email. But most of these positions for next year are filled. I know some students told me they were called for second interviews, and these are difficult to get. What do they give you? They allow you to work with their patients so that when you get into clinical, you're ahead of the game. All right? They also, many of them, pay you a small stipend while you're going through. And thirdly, they pull from the group of interns the people they're going to hire for nurses' aid positions. And that's real money. Not a fortune. But unless you're doing something better that really gets you top pay, you should look at an internship program. And last, what it does is get you a job when you're finished, and a good job, because the best internship programs are in the magnet facilities. Remember we talked about magnet status. They're in magnet facilities, and they orient you for about 9 months, some of them. Of what value to them are you while you're being oriented? They do allow you to work, but you're given time off to go to classes, and you're exposed to every new thing going on in the institution, and you're seen as a premier employee. All right, so when you go to interview for an internship or an externship, as they call in some places, or for a job anywhere, precise and detailed job descriptions are the death knell. If they're too specific in what they want you to do, you don't want to be there, quite frankly. You may have to be there, and you can work around it, but it doesn't give you the best vibrations to start with. Management by memos in situations where personal communication would have sufficed is a bad sign too. All right, if you're in Burger King and every employee is sent a note about washing your hands after you leave the restroom, post one in there. I do know of one Burger King where everyone was sent one, given one in their paycheck. I mean, why do you have to? You say it. You don't have to memo people on all of these things. I know it gets the message across, but it's a sign of a weak person, a weak manager usually. Guarded interdisciplinary boundaries in nursing. The nurse never talks to the doctor. You only may talk to the supervisor, who then will talk to the doctor. You talk to whoever you have to talk to in order to facilitate the care of the patient, and then you chart that. A hierarchy, that is an obstacle to your work. Policies, procedures, and documentation systems that are cumbersome and inconsistent with practice. You see this a lot. One nurse I was talking to the other day, her boss asked her to go in the record and fill in all the blanks for the last month. This was in a nursing home, where communication often is minimal. but it's a state requirement that certain things be done. If it's inconsistent with policies, you don't do it. Absence of staff nurse autonomy in caring for patients. It's fine if you ask about the care of your patients to a degree, but don't be fooled. Stand on your own 2 feet. If a person is on a regular diet, and it's documented, that's the diet, and they ask for something to eat, you ask them. In other words, can you chew it? The meat, you don't have a problem with meat in case it comes and it's tough. No, I want it. If they're on a regular diet, you can order. All right? You don't have to go and ask the head nurse for everything. Verbalized discontent from staff and high turnover. Very common. If you're going to be take a job as an extern or an intern at a facility, there'd be nothing wrong with you asking, could I meet some of your employees, particularly if you're going for a regular job. Could I meet some of your employees? Would it be okay if I talked to some of them? You want to. And you want to know, are you happy here? Now, you use your common sense. If it's your boss that's taking you around, you don't want to ask in front of them. The person wouldn't give you the true answer anyway. But you look for the opportunity to speak to someone privately. And if you're going for a nursing job, this is quite possible. Or you see someone you know that's more and more likely in this state. You get in touch with them. Tell me what you think of working for X, Y, and Z hospital or for this nursing home. Tell me the ups and downs. And high turnover is at the end side. The magnets, turnover rate for nurses is usually 5 years. They don't stay more than, unless they've gotten promotions, they're very, very happy. 5 years is usually the max. And some of you are thinking, God, 5 years, so that's a lifetime. Not really. 5 years is vesting of a pension. You should know that. That's ERISA. ERISA, the National Pension Laws. In 5 years, if you are working somewhere and they have a non-contributory pension, they put money for you away each month. In 5 years, it's yours. And that legislation was lobbied by the American Nurses Association for women particularly and for nurses most especially because they knew the 5-year employment pattern. And right now there is a company that's creating business for itself, trying to start up, that captures your pension because most nurses have had 5 years in a lot of different places. So you have pension dollars in a few places, and most nurses never thought of going back and getting that. Just figured they were working 5 years, so what? They didn't stay a lifetime, so how could they get anything? But you do, you're qualified to go back and collect those pensions. Most colleges of nursing have some socialization experiences to help you enter the workplace. A synthesis semester at the end of the academic experience is what we have here. The last clinical course is leadership. And you can expect to get that experience in one of many sites. So what used to happen, I don't know if it still happens, but it did up until a year or so ago when I was doing it, I would ask students in the first part of their senior year, where would you like to go for leadership? The students usually told you one or two things: where they want to work when they graduate, or a clinical area they feel very ill at ease with. Either they don't like the patients and they know they get a plenary license as a nurse. Remember, plenary. It's not a specialty, it's a plenary. In the UK, it used to be a specialty license. Now they're converting to our system. In other words, you get a license which allows you to take care of any type of patient. You can go to OB, pediatrics, med-surg, gerontology, community health. You can work anywhere, a plenary license. And so a student who feels very ill at ease in pediatrics, don't know why, but they just never, and maybe it's because the instructor they had was mean, all right, and so they were turned off by pediatrics, feels this is a deficiency in their background, and they would like to go to pediatrics. Another one wants to go to a community mental health center, a psychiatry, because that's where they want to work when they get out, and they figure they can make some contacts, they could really see if they want to go there. They think so now, but they want to be sure. So the last experience, and you can do leadership with any population. So we usually try to provide a range of settings so that everyone is happy, all right? Other programs do it differently. Some have no synthesis, so you never get that type of experience. Others are work-study programs. You've heard of work-study. The closest one to here is Drexel in Philadelphia, and there's one at Northeastern in Boston, which is the oldest one. In those programs, you go to school for a year or 2 years, and then you're off 6 months or a year. And you have to have your work placement approved by the school, but you work 24, you work 8-hour days, you're treated as one of the staff, and it gives you an idea how you're going to fit in after you finish school. It's an exceptional thing, but it's a type of synthesis program. Then there are curriculum which progress you towards independence. If you want to read about this, go to the, there is an article that, Google it up or go to the Rutgers Library website by Gene Watson, W-A-T-S-O-N, and it's written about University of Colorado, and they have a program where the instructor and the students go through different roles as they progress. In other words, I mentioned this once to you quite a while ago. Maybe it's more relevant now, but the student starts where the instructor's in charge, in control. And by the time they get to the last course in nursing, the instructor is only a consultant to the students. That will shake you. In other words, in the morning when they're discussing how they're going to treat their patients, or if they're having a seminar discussion about the management of patients with congestive heart failure, it is up to the students to give the answer. And only if there's a complex patient or a tough question do they turn to the instructor. And the students are graded to be able to assume that role. How would you know all this stuff? A dramatic amount of out of class and today computer work. a dramatic amount. And you wouldn't come in to a class where you're going to discuss the congestive heart failure patient without having spent, I would say 5 hours for every hour you're going to be in the room, looking up and trying to understand how you give care and what programs exist. Very challenging program. But one that's been in operation a lot of years now, and it'd be interesting to do some comparative data collection to see if students in other types of programs do as well. And then there are service education partnerships. Rutgers led the nation with this, and there's an article published in the American Journal of Nursing quite a few years ago about the Rutgers model. We had, at one point, at least 20 instructors who were half with our students, half of their time, and the other half of that time in the healthcare agency giving care to patients, so that they taught you on their patients. So they knew those patients inside and out. They knew the agency because they also worked there, which allowed you access to special experiences. You were treated like a member of the staff, which is always, medical education is like that. Student physicians are taught by practicing physicians. They know they're going to have a student with them, and they accept it, and they teach the student on their patients. That has always been the way medicine has been taught, but there are a lot fewer student physicians than there are student nurses, and there are rules that we have to live by, which is the 1-to-10 ratio in the state, 1 instructor from Rutgers with every 10 students. So we have to, in some way, accommodate that. But the service education partnerships are wonderful, and we still have a few of our faculty who are half paid by the agency and who have the students in on the floors they're working on. We have, Dorian McNish at Centra State in Freehold is one of those people. She's a very seasoned nurse, and half of the time she is working for Centra State as an advanced practice nurse, and half of the time she has our students down there. We talked about summer extern or internships. New graduate residencies is an experience with a new flavor. And it's one that was promoted heavily by the Future of Nursing. Future of Nursing is the IOM report that was released 2 years ago. It's important that you know about it. It's iom.gov. You can download the whole report. It was heavily funded by the Robert Wood Johnson Foundation and is attempting to shape modern nursing. One of the things it promotes is that new graduates don't go directly to work. They go into a residency first. Now, how do I feel about that? One part of me says it's wonderful. I think, in a way, the extern internships do the same thing with an orientation that is magnificent. But new graduate residencies guarantees that you're part of the workforce, but your education continues at the beginning of, all right, what are the downside? How are you paid? A union would ask that immediately. They would say, you're getting free labor, because most new graduate residencies, you're paid less than the full rate. It depends if you think you need it, or you need the money more. Probably you need the money when you're finished with Rutgers. But most people need the experience and the fact that that is going to almost definitely guarantee you a full position. A lot of places like these residencies because they can look at you. You understand what I mean? It's not a full position, so they can still let you go. Particularly the magnets are very concerned that they get the best. All right, patient areas exclusive to clinical teaching. The Future of Nursing report and our own collaborative center. You know, we have a collaborative center here at Rutgers that is funded by the state of New Jersey through my license fees. They take a certain amount of every nurse's licensing fee and give it to Rutgers for the collaborative center. The collaborative center does a lot of work analyzing the hiring practices in New Jersey. And one of the things it's pushing right now is the DE unit, Designated Educational Unit. These are units in hospitals mostly, but could be in nursing homes, could be through home care, but are mostly in hospitals that are used exclusively for student teaching. So, you have the optimum number of nurses, everything is done according to the letter of the law, and it's used for students who come from schools of nursing. It's not a new idea, but this is the first time we've had a lot of attention. Buddy systems. Most new jobs, when you go to work there, will link you up with a nurse, a senior nurse. Well, not senior, a nurse, somebody else who's been there before you. And it's called a buddy system. That person has an obligation to see that you understand things, that you're competent in your skills, to take a special interest in you. And usually, that person is compensated for that role. I don't think they should be, but most hospitals have put them on a different level than the other nurses. They pick these people out very carefully. They don't want someone who's going to be spewing heresy about the institution, telling you what a bad place it is to work. They're usually people that are upbeat. And an experience with interdisciplinary education. We've been trying to do this for centuries. The best way to get physicians and PTs and pharmacists and nurses to work together is to educate them together. Over the years, we've had a few experiences. We have had summer seminars with HIP and had the medical students from UMB and Jen come over here and given it to nurses and student physicians together, worked out very well. We've had this course open, and I'm talking about over 30 years, different things, but it never quite takes off. Right now, Dr. Pearson, she's one of the associate deans, is trying to push forward a program to do continuing education with all the disciplines together. What do we have at the table? Pharmacy, PC, osteopathy, chiropractors, nurses, everyone. And we're finding that some of their continuing education needs would lend to doing things together. But what do you think holds us back from doing things together. What do you think? Now, we've talked about the different disciplines, their education. What do you think? Anyone? No? They're not educated at the same level. You put a bachelor's nursing students in with a post-baccalaureate PT or a post-baccalaureate PharmD, they're not at the same level. So, as I've been thinking this out, I think the perfect partners for interdisciplinary education would be the advanced practice nurses with physicians. They're doing different things, but that's good. You want them to get out of this realizing that they're all different. And nursing does have the corner on the market. There's more of us than anyone else. We're quickly becoming a career choice for men and women. It used to be the thought that women put us in the position of being dominated. We have now about 20% men, and that is increasing. A piece of information for you just this week. A major bill went through Congress funding baccalaureate programs in nursing for vets. You've got to get a lot of poor men and a lot of men in that program because there are wonderful women in the military. You will get some of them, but they're overwhelmingly men. I don't know if Rutgers, I hope Rutgers will establish a program because the success we've had with the New York Fire Department and police has been awesome. So it's a real opportunity to move people to a higher level and then to promote some interdisciplinary education. And there is money for interdisciplinary education if you can figure out a way to make it happen. All right, let me give you 10 minutes to stand and stretch and take a breath, okay? Why don't you do that?
Hi, Professor. My friend Daniela Kingston, she wasn't able to come today.
She hasn't been here long.
Yeah, she wanted to hand in the paper, and she said multiple times that you didn't get it.
No, I didn't get it. There's nothing wrong with my computer.
Yeah, she wanted me to give it to her.
Okay. Where is she?
Well, today she had a high fever, so she wasn't
Okay,
able.
she's been absent many times. Tell her that. I know it.
Okay.
And I've held back reporting her, but it's an issue. Okay.
Okay. Thank you.
What's your No, it's not. Not if you know what to do. Not and you read. Two. Have psychopaths. It's not. Not anymore. It's a wonderful application. Nursing all population. And then it's like just because your license is, are you in the nursing program? Okay. You haven't had any go next. No? You got 2 years before you're going? All right. Next year, during the month. Like you. You can't take both. Bigger. In this country, the licensure that means you work with all sorts. You don't specialize, but what you do is your job. You become very used to one occupation. You understand? And but the license. If you get your already, talk to me. What do you do? It's a course. Yeah, I think so. Yeah. But, and they'll give you the criteria they use for grade. They tell you, like, very much choices, ones that. You grow to that, but you go through other things first. All right? Yeah.
Just to clarify, I think, that you said
Whatever's on the website is correct. An announcement went out. All right, wait a minute. The review is in Tuesday. The exam is in Atkinson 120. Right. Okay. Review is here 10 o'clock. And exam in here 1:45. 11:45. No. It's on the website. Announced. Yeah. The exam is across the street in room 123, 11:45. Okay? You're welcome.
you got the Jeopardy program.
What?
Remember the Jeopardy program or something?
Oh, I'm gonna check it because I have so much thing. Thank you. I have to go check.
I sent it to everyone.
Yeah, thank you.
No problem.
regard, in case you didn't know it, the job that you're going to start in nursing is very stressful and dangerous. It's stressful because of the quick pace and the problems that people bring to you. And it's dangerous because there are a lot of things you have to be wary of in the work. Infections, personal jeopardy, etc. So, what I am saying is that stress and strain are going to be your constant companion. I would urge you to read this part in the book. There are a few good suggestions to deal with this. First, use distance therapeutically. And I think we mentioned this 2 weeks ago also, so I'm not going to hang on it. But always find a place where you can go to be alone. Decide who owns a problem. This is a real treachery of nurses. Nurses go into nursing because they have a feel for the human condition. They want to help people. So you meet people with a problem and immediately you want to help. You want to help everyone. You can't help everyone. Decide who owns a problem. If it's your problem or if you're paid to manage it, you intervene. If it's not your problem or you're not paid to deal with it, you don't. Develop a good support system, and I mentioned this to you before. Sometimes support systems and people become a habit. Get rid of the habits. Expose yourself to new things, and most of these things are common sense. The second one here is something I always use for myself. I think in terms of what could be the worst consequence. And if the worst consequence happens, what can I do to recoup the situation? The worst consequence in here is that you fail. What are you going to do if you fail? How is it going to derail your plans for life? Is it going to get in the way of you progressing in the program, etc.? With your personal life, what is the worst consequence, and how are you going to deal with it? Maybe that's making it more realistic. Identifying one person who could be your sounding board is critical. All right. Now the important stuff. Your rights and responsibility as a worker, as a nurse or as a nursing assistant, or generally in other positions, but this really is geared to address nursing. Can you be fired without a reason? Just fired? Yes, if you're an at-will employee. An at-will employee is someone who has not got the protection of a union. If you're an at-will employee, you can just be fired. They don't have to give you a reason. Now, if you feel there's discrimination, etc., then you have to weigh, is it worth your effort to lodge complaint? You have to make that decision yourself. But an at-will employee, one who is not represented by a union, can be fired. Policy manuals have the force of contracts in this country. I can think of a situation years ago. I worked for a hospital. And it was a lot of years ago, and we really weren't given any sick time. We were never told we had sick time. We always operated on the basis that, well, if you were sick, then one day now and then, but you got no extended sick time. One of my colleagues became quite ill and needed several weeks off for recuperation. We had never been given any policy manual when we started the job. Lo and behold, he found an old, dusty policy manual. Must have been 20 years old. I don't know how he found it, but it designated time there for prolonged illness. And any policy manual that you have, unless you can identify a definite action by the board of directors, and that is who is responsible for an institution. We learned that when we talked about institutions. It's the board of directors that has the ultimate responsibility. Unless a board of directors has rescinded that policy manual and there's documented evidence, the policy manual is enforced. And he got 4 weeks paid sick time. So I thought that was a coup, and it impressed on me that policy manuals in this country have the force of a contract. So when you get a policy manual from your boss or from the hospital you're working in or the nursing home, make sure you keep it. And today, most of those policy manuals are on the internet, so you can go there. What is a successful appeal of termination? If you are discharged and you want to appeal, what do you have to include in that appeal? First of all, you feel the charges were never proven. That's critical. The severity of the consequences is inappropriate to the charge. And I can give you many. All right, one patient of mine, nurse, was let go from her job. All right, she was called in by the director of nursing to talk to. And the director said she smelled alcohol on her. This is a woman who has been dry for 15 years, has not drank for 15 years. And she's in AA. She finds a meeting to go to 3 times a week. And if any of you know AA members, they become very committed to the program. She goes because she feels she's of support to the other people who are there. It's, if you talk to her, it's part of her life, going to meetings 3 times a week. I joked and said to her, do you do anything else? You know, 3 nights a week I was running to meetings, but it's part of her life. So she was called in by the director of nursing. And there was a rub between the director of nursing and her. They had asked her to do some charting on situations in which she had not been involved. And she told them she wouldn't because she did not see this behavior. And she did not check the patient that day. The patient was not assigned to her. So there was a bad relationship there to start with. The director of nurses called her in and sniffed and said, do I smell alcohol? She said to the director of nursing, and no one else knew about it, she said she was sort of taken off guard. And she said to the director, I'm a member of AA, and I haven't had a drink in 15 years. That was it. She was discharged immediately on the pretext that she must have been drunk. You follow? And they didn't ask her to take a blood alcohol. She should have demanded that a blood alcohol be taken. That consequence was inappropriate to the charges. There was no proof of anything. But she, unfortunately, she lost her job, and they also reported her to the Board of Nursing. She had her license suspended for nothing, for being honest, for slipping up and opening her mouth when she should have just said nothing. So if you can prove that the severity of the consequences is inappropriate to the charges, that's another reason for successful appeal. The reason for dismissal is unrelated to the job. This is another. I have another nurse who had been drinking, and don't get the idea that nurses drink more than other people. They don't. Nurses are drug abusers and alcoholics are present in the nursing population to the same percentage as they are in any other population. That's been proven, all right? But it just so happens I have another nurse who had been drinking. She has an alcohol problem, and she was scheduled to go into work. She's an emergency room nurse. She didn't go in. She sat in her car and fell asleep. And they found her out there 4 hours into the shift, and they let her go. They discharged her. But it was unrelated to the job. She did not go in. She was not. Now, was that alcoholism or that drinking related to the job? I guess some shrewd attorney could build a case, but she was not near the job. So that's another. She's trying to beat it on that. Now, you might say, who wants to work there? If this is their perception of you, they've caught you out in the parking lot, who wants to go back and work there? It's easy to say, it's not so much the work, it's the dismissal. You see? And being reported to the Board of Nursing, and that's what they did. All right. Customary disciplinary procedures are not followed. In every place you work, you'll find there is a procedure outlined. You're reported to your immediate supervisor. From there, you go to HR, and there is a procedure for reporting disciplinary situations. If that's not followed, that's another reason to appeal. Is it possible to refuse an assignment? That's a good one. Among your rights and responsibilities. Floating is when you are allowed to be reassigned to different units depending on the institution's need. In most contracts, there's provision for floating. And if you go to take a job and there is no provision, it's your right to inquire. Since I see nothing in the contract about floating, I'm assuming that I will not be changed or sent to different units. The unit I'm prepared on and the unit I'm assigned to work on will be my permanent unit. Most people today, that isn't the case. There's some provision in the contract for floating, and some people find it helpful to their own situation to work as floats. In other words, some nurses take a job where it's assumed they will be floating, and they usually pay an amount more above the standard wage for that. It's one thing to be floated anywhere. It's another thing to be floated within your specialty area. And to be floated outside of your specialty area, I think you could refuse that, say that you're unsafe. You're not prepared to work in that. One of your classmates asked me about psychiatric nursing. She's just starting the nursing program, but she's already interested in working in psychiatry. I said to her, you're preparing for a plenary license through these courses, which means you're prepared to work with any usual population. Infants and babies and mothers and medicine and surgery patients, community health, psychiatry. You're prepared to work with all of them. But once you go out and take a job, you become specialized very quickly and should look to taking a certification exam. Remember, that's the exam that says you have competency in a specialized area. The first level of certification gets you more money and stakes out your turf. You're a psychiatric nurse, you're a pediatric nurse, etc. It's not graduate preparation, but it begins to recognize you as specialized in a certain area. Because as soon as you spend a few years in one area, you're unsafe to float. So I would say it is possible to refuse. You are hired as a nurse and you have a plenary license, so which means you could work anywhere. But if you know that your skills are rusty because you have never wanted to, nor have you taken care of that type of patient, I think it's possible for you to refuse nicely. You have to learn how to do these things nicely, but it is possible. Mandatory overtime. We have a law in this state, very loose one, but we mentioned this weeks ago. It was abusive. Nurses were being expected when there was a dramatic shortage of nurses. There is not now. But when there was a dramatic shortage, there were many units that were without a nurse because the nurse didn't come in or something of that sort, and the boss expected the nurse who was on duty to stay until she was relieved or until he was relieved. And often, this was 8 hours later. It became unsafe. So we have legislation that says that you have to be asked and you have to give permission to work mandatory overtime, and so you can decline. The problem is, when we were working on that legislation, the chief people to try to avoid it being passed were nurses themselves. They liked the overtime. You would get time and a half, or some places double time for overtime, and they liked the money. They didn't want the employer to call another nurse to come in. They'd rather stay. They were there, so you stay 4 more hours. So what? And when you get 8 hours paid for that, that's pretty good. But you can't refuse all mandatory overtime. You have to let common sense prevail. If you're tired, you're unsafe, so you should refuse it. All right? And there are state laws in this state which protect you from being taken advantage of. If any of these situations occur, floating to a place you haven't worked in labor and delivery, oh, God forbid they should send me there. But, I mean, that is highly specialized. When you see babies dropping out all around you, and you don't even know how to cut the cord. But anyway, if they're going to send you someplace you feel you're incompetent, or if they're floating you every day, you know the call's going to come at 3 o'clock. There's no one to relieve you. Stay till 7. You can accept the assignment under protest, and there you can just make out your own form, or there are forms provided, usually through the state nurses or the union. Very simple. just your name and your unit, and explain the situation. Very short and brief. Contacted by so-and-so and told I was required to float to labor and delivery. I have not been near labor and delivery for 15 years since I graduated, never had any interest in it. I would be unsafe. And so I refuse to go, or I accept the assignment under protest, right? Always, it's best to make out one of these forms, particularly the under protest, because even if you feel you're unsuitable for the assignment, you're legally responsible. So if a baby is born and you don't know the signs of fetal distress and you can't put into operation the proper procedure quick enough, you are responsible. You're an RN, and that's all they need, an RN. Now, if it goes to court, all these other things will come out, but you are responsible. So, assignment under protest really means that you're accepting the assignment as a babysitter. You understand? There's a requirement for an RN to be on the floor. You're an RN, you're there. Of what value you are, you don't know, but they're complying with the state law. Religious preference is another big thing. Religious preference versus religious obligation, too. I'm throwing this out. You don't like to work on Christmas. Well, I had a nickel for every Christmas I worked. The holidays go to the most senior employees if they want it. And frequently you have senior employees who are very conscious of your obligations versus theirs. And if you have a family and they don't, they'll say, go ahead, take Christmas. I've been home enough Christmases and I'm happy escaping, so they'll let you have the day. But religious obligation is something else. The Sabbath, or other holy days or holidays which you are not allowed by virtue of your religion to work. I can't be more eloquent on it. Probably you could be. But you have to divulge that before you take the job. It would be discriminatory to eliminate you for a position because you have those preferences. But you should straighten them out before. Now, religious preferences also covers patients and situations like termination of pregnancy, assisting an abortion. And remember what you were taught. You have to separate yourself and your religious convictions, what you would do for yourself, from what you would do for a patient. If there's no one else on duty, and these procedures are occurring, if there's no one else there, that patient is in jeopardy because of you, if you eliminate yourself. So the first thought is it necessary for me to be there for my patient? But if you can, in some way, exchange assignments with someone else, and luckily, you live in a densely populated area. All the major hospitals around here are big, they have a number of staff, so you talk to the other staff, or make this clear. And if you're a desirable employee, they will switch with you. I've never seen a situation where people wouldn't. But you have to keep your religious convictions separate from what you spew at the patient. The fact that abortion is something hideous in your mind and something that you would never participate in is fine for you. But the patient has the right to make up their own mind and should never see in your eyes any disapproval. That's the hard part. Never even suspect that there's any disapproval. And you have to feel the courage of your convictions enough to educate the patient. There is nothing wrong with asking the patient, and this goes into Jehovah's Witnesses and many things, but there's nothing wrong with saying, share with me your reasons. And what are the negative parts of this? How are you going to make arrangements for yourself if you're keeping a baby? What are going to be your arrangements for the care and the maintenance of that baby after it's born? There's nothing wrong with asking questions and that comes under being advised for consent. All right? But religious preferences should be shared if you have them. Oh, there are protections for whistleblowers. Now, you read about whistleblowers in your book. And a whistleblower is one who notices a grave wrong and has used all of the appropriate channels to resolve it, which means if you see things which are wrong, you go to your immediate supervisor. You give him time to respond. You alert him again, and all this can happen in one day. I'm not talking about months to iron out something, or weeks. If nothing happens, you mention it again, and you also mention that if he doesn't bring this to the attention of so-and-so, you're going to have to bring it. He might say to you, you do what you have to do, which is telling you, I don't want to be the bearer of bad news up the line, but if you feel you have to do it, you report. But whistleblowing has to use all appropriate internal channels to resolve it. And you will use the ethical theories you've been taught. You have to verify the facts. You have to make sure what you're telling is not your tale, it's true. Your primary loyalty is to the patient, not to your employer. And you have to be sure that blowing the whistle will result in more good than harm. And understand that your actions are very serious and assume responsibility for those actions. Now, I've told you about several cases in nursing homes in this state which were dealt with by whistleblowers. In all of them, I can remember, and your job is protected and your anonymity is protected. Whistleblowing means you go out of the institution, you do an end run around the administration, you go directly to the office in government which is responsible. Like a nursing home, you go to the office of institutions and agencies in training, and you make sure they hear your story. You have protection of anonymity. Nobody will know. But people have a weird way of finding out. And a lot of that way of finding out, I think, is your own, the whistleblower's attitude towards work. But no one can possibly tell who you are, and your job is protected. Your job is protected. They can't get rid of you because you blew the whistle. But again, the two nurses I know that blew the whistle on nursing homes in New Jersey were eventually, well, one resigned because it was so uncomfortable. She could never prove that anyone had slipped and divulged her identity. She didn't tell anyone what she did, but she had a feeling that people knew, and a lot of this is paranoia, is yourself, but she had a feeling, and she had a feeling she was treated differently, so eventually she left. And the other person also felt that he was treated differently and was accused of other wrongdoing, and he felt that it was a reprisal for having, it's not a happy scene. So the best, you are protected, definitely protected. And you've heard of some of these people who bring hospitals to attention because they're billing patients inordinate. Haven't you heard of that? They're misusing Medicare or Medicaid money, and the whistleblower gets half of what's recovered. There are deals like that too. In other words, if the whistleblower's intelligence results in $1 million being retrieved by the government, there is money given to the whistleblower out of that. I don't know how much, but one of those cases is pending over at University Hospital. And it's one of the reasons no one wanted to get mixed up with them. Medicare fraud. Okay, what protection do you have against discrimination? Age, disability, sexual harassment. If you feel you're being sexually harassed, and I don't know if anyone else has taught you this or told you about it, you immediately on the spot accuse the offender of sexual harassment. Immediately. Not, I don't like the way you're treating me, and walk away and then think the next day you're going to say something to your supervisor. You immediately say, I am interpreting this as sexual harassment. And you go from there to make a written report and submit it to your superior. You hear me? Immediately on this, and use the words. Don't find some more acceptable words. I'm interpreting this as sexual harassment. But also, be careful that you know what sexual harassment is. And most orientation programs today in the workplace orient you to what sexual harassment is. And sexual harassment doesn't have to be physical. It can be physical, it can be verbal, it can be gestural. I'm interpreting this as sexual harassment. Zoom, go, document it, and put in a report. It's the only way that, all right, will your job be in jeopardy? Yeah.
Sexual harassment, like with the patient?
Anyone. Patient, doctors are big offenders, let me tell you. Doctors, your boss, the president of the corporation that makes rounds and gives you a feel. I mean, these things may be far from your imagination, but you turn around and you say, excuse me, did you realize what you just did? I'm interpreting that as sexual harassment. You can't let people go get away with this. It doesn't matter if you're man or woman. It's still sexual harassment. Understand that? Yeah. Age. There have been a lot of age discrimination suits. There were several. There are 2 noted in your book. But since then, there have been several more. And the way you keep on top of this is to go to LexisNexis. LexisNexis, cute name, isn't it? LexisNexis. Lexis is the law, Nexus is the regulations, and it's over in the law library. You have a right to use it. And I don't know if you can get in from your home computer, but I would not be reticent. The librarian over there is wonderful. Ask her if there's a code you need or what to get in. It has Jefferson.gov has all federal laws, and there's a state site, but LexisNexis will have all of the cases which have been found lately, and there have been several additional cases found with discrimination on age of nurses. In other words, all right, what were these? One of them, very recent, was a nurse who, it was a hospital that had a clinical ladder. A clinical ladder is where you come in at the bottom, usually, although if you're baccalaureate, you come in at step 2. Each step has different responsibilities and a different pay scale. You make a little more. So step 1 is for the new graduate of an associate degree or a diploma program with no experience, no nothing. Step 2 could be diploma graduates that have been there a while and prove their competency, or a new baccalaureate, and you continue to climb. A lot of hospitals have a requirement that you must climb. In other words, they don't want people who are going nowhere. You have to climb. Now, you may not have to climb all the way to the top, but you have to go somewhere. You can't stay forever as first rung. And there were several nurses who brought a suit because their employer discharged them since they had never continued to progress up the ladder. They were nurses with a lot of experience, and they were older nurses, and they were claiming that they were discriminated against because of age. And I guess their age did have something to do with it. Looking at the testimony, they didn't want to do all that you had to do to climb higher. They were satisfied where they were. They wanted to take care of patients. They had done that for a lot of years. They were very good at it. This was the testimony. But they didn't want to go and get certification. They didn't want to get a lot of continuing education. And the decision was found for these nurses. And they were given damages. Very interesting. Disability. Unless your disability gets in the way of your job description, you have to be protected. Now, I've had students who are missing arms, who, I can think of one. She's a thalidomide baby. Any of you studied thalidomide? Was a drug given to pregnant women way back. And it resulted in babies with bud extremities, one or more. And I've known several people with bud arms. And this one student, I had her years ago, she was phenomenal. She could manipulate anything with that bud. She used the bud. She didn't like the prosthesis. It got in her way. And she had developed dramatic skill with the other. Who knows whether she would have been right or left. The right arm was gone. She used the left. But she did everything. And fast. And she was a very competent nurse. She's with the World Health now in Tunisia. She has developed a wonderful career. So you have to be careful. What is a disability? If you have a disability where you can't comprehend, and so you can't give care in a quick enough fashion, this might be something, although there are other nursing jobs that you could qualify for. It's a very stickly thing. And particularly when you come become disabled after you've already started a career. And sexual harassment, we've already discussed that. Do I have a right to withhold information about myself for the employer prior to a conditional promise of employment? Now, you all know drug testing can be required for a promise of employment. I was in one of the, one of the labs myself about 2 or 3 months ago on a Saturday morning, and the waiting room was full of people. I asked them, what are you all here for? I thought there was some outbreak of something in the area. They were all there for pre-employment drug tests. You can, but you have to be told that. All right? A physical examination should never be done pre a conditional promise of employment. Never. You do not have to submit to a physical examination. It's illegal. All right? If something crops up, the test is it going to stand in the way of you meeting the requirements of the job? All right? Showing up to work on time, etc. And I feel it's a very difficult situation. It's very offensive if a person hides something and waits to get the conditional promise. Because then, if you're going to claim it's not going to get in the way of your employment, and it does, you're using this as a smokescreen to suck an employer into giving you a job. Take, for instance, ramp participation. Nurses who have been substance abusers. An addict is protected by the Americans with Disability Act, as is an HIV positive person. Those are all protected classes. As an HIV positive person, you should know the policies of the profession. Nothing deep, dark, and sharp. Remember, we talked about that weeks ago. Some of you did your papers on it. Any job which requires you to work deep, dark, and sharp is definitely off limits for you. But you're a protected class. You can take the job and then create the problem for the employer. That would be a very good test case. Did you have the right to take that job? Knowing that a job as an OR technician, I don't care if you're wearing gloves. They perforate very easily. You're wearing double gloves. But it's a problem, and it is a protected class. So you're creating a problem for the employer. Any questions about that? It's a very stickly situation if it's you. All right, the major workplace hazards for nursing. MDR-TB is multi-drug resistant TB. We have drugs to combat tuberculosis today, but there have been a lot of people who have ignored their tuberculosis, and due to the strains which have been developed and mutated over the years, we now have multi-drug resistant TB. In other words, TB that isn't touched by any drug possible. Streptomycin was the big miracle drug for TB, discovered at Rutgers, remember? Discovered at Rutgers. But today, we have so many mutations that multi-drug resistant TB is a threat. What do you do about it? You do what the employer tells you, and you remain very current on what the National Institute of Occupational Health and Safety says about this. NIOSH, we talked about NIOSH last week, and OSHA, their regulation. If you're working in a place where this is common, you just be very careful that you know the rules and that your employer is attempting to follow those rules. Any questions about multi-drug resistant TB, HIV, AIDS, same thing. There are universal precautions. There are very detailed requirement for the disposal of medical waste. Make sure your employer is doing that and you're conforming with the requirements. This is not fun and games. When I think someone I know was at Pain with me, that's one of the pavilions of New York Hospital last year, and I went over to see him. He had AIDS. I didn't know it before I went over, and I knew it when I got there. All of the people on the floor worked with respirators. They wore portable respirators and hazmat suits. It was a place for multi-drug resistant TB mostly and AIDS, which they have since repatterned that unit, and they only have multi-drug resistant TB. It's a very hazardous environment to be in, and usually there's extra pay for people who agree to work in those situations, but you have to make sure you're protected. And they felt, and this is a state-of-the-art place, that anyone working with this population had to be gowned and wear hazmat and an oxygen tank, because it's spread by droplet. And can you imagine the suits if people were to contract TB who worked there, the workers' comp suits. Another hazard is violence, particularly in emergency departments. Let me warn you, and I know a lot of emergency nurses, and there's violence with a little v and a big V. There's major violence and there's threats. But in an emergency situation, you get this. I'm sure you see why. People come in who are the results of violence on the outside. They bring the violence right with them. Or people are brought in and people come who are lovingly attached to them and they begin to act out. So emergency departments are a great place to see violence. If you want to do a paper on it, go to the Emergency Nurses Association Journal, ENA, and they have it online here. They've done wonderful research on violence in the workplace and how to deal with it. It's a prevalent threat in emergency rooms. Yet, people who work in emergency will not work anywhere else. And my observation, I have not done the research, but I have 20 years of working with substance abusers. They are predominantly nurses who work in emergency and intensive care. Why? The stress. And you reach out, and Mr. Jones only wanted one pill, and he got two in your hands. So it's one for Mr. Jones, one for me. The stress in those environments is horrible. And so you see a lot of violence, a lot of drug abuse. Ergonomic hazards is the most prevalent among nurses. Ergonomic hazards are things that happen to you from the workplace, from lifting, from repetitive motion. And there's a lot of government monies that have been put into it, from the Institute of Occupational Health and Safety, the IOM, a lot of studying a lot of rules and regulations to try to combat this. For instance, and this goes from the federal government and it filters down to the state, like quickly. There was a requirement put in the federal government for Medicare patients. The government pays for them. They're the only ones that you can dictate about. That every nursing home which accommodates these Medicare patients must have lift equipment. Bad backs from lifting patients is very common among nurses in long-term care. So the government put in this regulation, it filtered down to the state, and now in New Jersey, there are institutions and agencies, their nursing home regulations, you must have lifts to get people out of bed. All right? Hopefully, this will save a lot of backs. You must wear those waist things, those belts that close with Velcro to give you support on your back if you're working in a nursing home and lifting is part of your job. There have been a lot of improvements, but it's going to be a long time before we really get ergonomic hazards under control. Nurses have been heavily recruited by labor unions, and there are quite a few situations that make nurses unique. Nurses supervise other nurses, and that has been interpreted by the courts as supervisory domination. Unions have two classes of people, labor and management, supervisors and labor. And so nurses are caught in the middle. That's enough to say to you. There's also been a Supreme Court decision, I'm proud to say I was there when it was made, that nurses are so unique that they should have their own bargaining units. Before that Supreme Court decision, we were included by unions with everyone, floor sweepers, window washers, everyone else. Now, nurses are qualified to have their own bargaining units because we do things that other people would not understand. And that was the gist of the testimony. Okay. I'm not going to go into career mapping because I think you're just wondering how you're going to get out of this course. I don't know if you're career mapping, but know that you have to start thinking from the outset about, now, several of you, and I will be to you in the next few weeks, did superb papers. You should work on them a little bit more and submit them for publication. Now you're thinking, is she crazy? You know? No, I'm not crazy. Because when you go looking for that internship or a job, if you have down on your resume that you were in a leadership position in the student government or in the New Jersey nursing students, if you have a publication or you made a presentation someplace, immediately their eyebrows go up and they look at you as someone they want. Any questions about anything? Let me ask you, by next Tuesday, when we have the review, try to go through everything and put down your questions, because I'll be open to answering anything you want. Put down your questions, and we'll review content, but then we'll open it for some free discussion of whatever you want. All right, see you Tuesday. Sooner than you think. When is the last day of school? Monday, right? Yeah. So.